Good evening, my dear friends and colleagues. Today, inshallah, we'll continue part 2 of membranous, discussing membranous glomerulonephritis. In part 1, we discussed an introduction, epidemiology, etiology, and clinical picture and pathology. Today, we'll discuss, inshallah, in part 2, diagnosis, prognosis, and treatment. Our discussion mainly in part 2 will be dependent on KDIGO guidelines 2020 with its large main modifications in the management of membranous glomerulonephritis. We will start by diagnosis of membranous glomerulonephritis. Generally, diagnosis of membranous glomerulonephritis, as we know, usually dependent on a kidney biopsy. We do a kidney biopsy, or we found thickening of the glomerular basement membrane, then we define a patient as having membranous glomerulonephritis. However, nowadays, with the implementation of the serological test, we might not needing renal biopsy. Renal biopsy is not essential now to diagnose membranous glomerulonephritis if we have a positive serological test, either for positive serology for antiphospholipase A2 receptor or antibodies against thrombospondin antigen. If we have a positive serology, for these antibodies, we might not needing a renal biopsy or a kidney biopsy to diagnose a patient as having a membranous glomerulonephritis or a primary membranous, and we'll found the justification from the trials now. On the other hand, a negative test for these antibodies does not exclude, this is very important, a negative test for, if we ask for antibodies for antiphospholipase A2 receptor or antithrombospondin, and it come to us negative, this does not exclude primary membranous, because these antibodies have a low sensitivity but high specificity. A low sensitivity, it means that they are not positive in all patients of primary membranous, but high specificity, if they are positive, this patient is mostly a membranous patient type. Why they might be negative? They might give us a negative result because in some patients, despite negative serology in blood, we might have a positive glomerular staining. We can ask, this is an indication for biopsy. If I have a high suspicion that this patient is membranous patient, I ask for serology. If serology in the serum is negative, I can do a renal biopsy and ask for staining for phospholipase A2 receptor and thrombospondin in the biopsy. In addition, there is a small number of patients of primary membranous who are negative for phospholipase A2 receptor and thrombospondin associated membranous. To conclude, the rule now that serology, if the serology is positive, we don't need a biopsy. And if the patient has a negative serology, we should ask for a biopsy to make sure of our diagnosis, and asking for staining in the biopsy for phospholipase A2 and thrombospondin. Secondary membranous. What about secondary membranous? It represents about 20 to 30% of all cases of membranous. The most common causes of secondary membranous, we describe the etiology for membranous in part 1, but the most common causes are lupus, class 5 lupus, hepatitis B, malignancy, and drugs, especially الكابتوبريل, penicillamine, والجولد. Very important, the most common causes of membranous, systemic lupus, hepatitis B, malignancy, and drugs. In assessment of a patient with nephrotic syndrome with a high suspicion of being membranous patient, should take a thorough history examination, thorough physical examination, lab investigation. We should ask to exclude secondary causes. Again, during our management of any glomerular patients, we should exclude secondary causes first before diagnosing the patient as having a primary or idiopathic form. And investigation or our assessment will include complement, of course. Complement should be normal. Antinuclear antibody for lupus, hepatitis serology, hepatitis B surface antigen, and hepatitis C virus antibody. Chest X-ray for cancer, lung. Occult blood in stool for cancer intestine, cancer colon. Mammograph in women. PSA, prostatic specific antigen for, and digital rectal examination in men. And in females between the age of 20 and 50, we should exclude lupus. Don't we ask for these investigations because we know that the common secondary causes for membranous. For each one, we will ask a specific investigation. Complement, antinuclear, hepatitis C, chest, to exclude malignancy, and to the end. In adult, regardless of the age, malignancy is very, very, very important and very common cause. The most common GN associated with malignancy is membranous. The most common malignancies associated are colon, cancer colon, renal cell carcinoma, and lung cancer. Tumors, this is also a very important note. Tumor may not be evident at time of presentation. From our practice, we have seen that the malignancy might appear before membranous, or at the same time of presentation with membranous, or after membranous glomerulonephritis by years. So malignancy can come before or at the same time or after membranous. We should exclude malignancy when we are dealing with a membranous patient. What about the hepatitis B associated membranous, hepatitis B virus? It is a common secondary cause in countries where hepatitis B is endemic. It can affect both adults and children with different outcomes. In children, usually present by nephrotic and usually follow a benign cause, while in adult it is usually much more aggressive, with there is progressive renal impairment in most of the cases, with a good response to antiviral treatment and tacrolimus. And membranous secondary to drugs usually resolves after the discontinuation of the offending drug. The time to resolution is variable, usually from 1 week compared to several years after the drug discontinuation. So it is different from one patient to another, but the most important thing is to stop this drug causing membranous. What about the KDIGO? For KDIGO guidelines for diagnosis of membranous. Practice point 1, that biopsy, again what we have said, biopsy may not be required. Very important rule that have changed in our practice with membranous. A kidney biopsy may not be required to confirm diagnosis of membranous in patient with clinical and serological presentation. What is their justification and what is the evidence for this? Usually, kidney biopsy was the gold standard, of course, for diagnosis of all glomerular diseases. But however, in membranous, especially in membranous, the antibodies against especially the phospholipase A2 receptor is a very good biomarker that can establish the diagnosis of membranous with a high accuracy. Without needing any essential more data from the kidney biopsy. A very recent study confirmed this high accuracy for membranous, sensitivity of around 64%. Very important numbers that you should know. The sensitivity and specificity of antiphospholipase A2 receptor antibodies. Sensitivity of around 60% and the specificity of what? 99%. 99%. 95 confidence interval for specificity is 0.96 to 1, comparable to the diagnostic performance of kidney biopsy. This is the clue. Meaning that the specificity of antiphospholipase A2 receptor is comparable to that of the kidney biopsy. So we don't need a biopsy in patient with positive antiphospholipase A2 receptor. Type. Very important. We'll discuss the assay for antibodies for against the phospholipase A2 receptor, and then we will discuss now when to consider a biopsy in a phospholipase A2 receptor positive patient. If patient with a positive serology, we might need a kidney biopsy. We will discuss the situation now. And also in patient with phospholipase A2 receptor negative patient with negative serology, as we said, we should ask for a kidney biopsy with a staining of the biopsy for phospholipase A2 antigen, A2 receptor antigen. If a patient have a positive, we don't ask for a biopsy, but we now know when to ask for a biopsy in a positive patient. If a patient have negative serology, we should ask for a kidney biopsy with a staining for phospholipase A2 receptor antigen type. This happened because it might be positive staining in the biopsy with negative serology. When the ELISA and the immune fixation is falsely negative, immune fluorescence technique, for example, due to what are the causes of having negative serology with positive staining for the phospholipase A2 receptor in the biopsy. Why it is positive in the kidney tissue but negative in serology? This might be due to low titer of the antibodies, and also another theory that in the very early phase of membranous, these antibodies might be absent in the very early stage, being captured in the kidney, and they will be detectable later. Now we will talk about the assay, the phospholipase A2 receptor antibody assay. It has now become one of our essential tests in our management with membranous, so we should have some details about the assay. The most detection of phospholipase A2 receptor in the serum might be detected with three ways: Western blot, immune fluorescence, and ELISA assay. Of course, the most sensitive is the Western blot technique, and the least sensitive is the ELISA technique. Western blot, usually it is not commercially available. What is more available is the immune fluorescence test and ELISA. Immune fluorescence is more sensitive than ELISA. The results of the immune fluorescence usually negative or positive. Some centers provide a semi-quantitative scores, as we see here. What is common in our practice in most of our labs is the ELISA technique, using a lowest cutoff of 14 reference unit per milli. 14 values between 2 and 14 are equivocal, and retesting in these cases with immune fluorescence technique might show positive results. Okay. A suggested algorithm for using a phospholipase A2 receptor assay in the management of membranous is shown here. In cases of positive serology with phospholipase A2 receptor associated membranous, we should measure الأساي or antibodies at 3 to 6 months interval. And in patients with a very high levels, more than 150, we might measure the antibody at a shorter interval, less than 3 months. In follow-up, if there is disappearance of the antibodies, this usually occurs with remission and no additional therapy is needed. While if there is persistence, positive or presence of antibodies after 3 to 6 months of therapy, this usually denotes that there is still persistent activity and we should reconsider therapy, as we will discuss it later. So we should ask for the assay during our management. This will guide us in our management, either if we are in remission and we don't need additional therapy, or if there is persistent activity and we should augment our therapy or change our therapy protocol. A higher levels with ELISA having a lower likelihood of spontaneous remission, because usually it is more aggressive and higher likelihood of non-response. So a high titer is usually associated with low remission and non-response. Another issue, when to consider kidney biopsy in positive patient for antiphospholipase A2 receptor. If a patient having anti-PLAR positive, patient have antibodies against PLAR, when we can ask for a kidney biopsy. This is also a suggested algorithm. If the test is negative, if the patient have a negative serology, we should ask for a biopsy, of course, to confirm our diagnosis. But if the patient have a positive test in serology with normal kidney function, no biopsy. There is no need for biopsy in this situation. This is very important. But if a patient is one of the high risk categories and immunosuppression is needed, we should ask for a biopsy. If there is deterioration of the GFR, we should ask for a biopsy. If the presentation is unusual clinical presentation, we should ask for a biopsy. If there is serological abnormalities like positive antinuclear antibody or any suspicious of secondary membranous, we should ask for a biopsy, and we discuss it in part 1 from the pathology, from the renal biopsy, how can we differentiate, what are the differences between primary and secondary membranous. And if the patient is unresponsive to immunosuppression, and if there is progressive kidney damage with treatment despite disappearance of antibodies in serum, we should ask for a biopsy. This is an important question and an important clinical scenario in our practice, when to ask for a biopsy in a patient with a positive antiphospholipase antibodies. if we need immunosuppression, if there is deterioration of the GFR, unusual presentation, unusual serology, and unresponsive patients despite disappearance of phospholipase A2 receptor, then in these situations we should ask for a renal biopsy. Practice point 2. In any patient with membranous, any patient with membranous should be evaluated for associated conditions, which are the common secondary causes. We are searching here for the secondary causes of membranous, regardless, this is important, regardless of the serology, are positive or negative. Every patient with membranous should be evaluated for associated conditions. We should screen for malignancies, ultrasound of the kidney, virology, full history, systemic diseases, thyroid, and physical examination, anti-nuclear antibody, drugs, non-steroidal gold and penicillamine, and chest x-ray for the possibility of sarcoidosis and cancer lung. يبقى to resume diagnosis, that new recommendations that kidney biopsy may not be needed in patient with positive antiphospholipase A2 receptor positive serology, and in every patient with membranous we should exclude associated conditions regardless of the serology. What about the prognosis? Prognosis of membranous in KDIGO 2020. In patient with membranous, we should use clinical and laboratory criteria to assess the risk of progressive kidney function, progressive loss of kidney function. We should use clinical and laboratory criteria. Why? Because spontaneous remission, this is also an important note in membranous. Spontaneous remission, as we all know, can happen in 1/3. It's very important. Spontaneous remission can happen in around 1/3 of patients with membranous glomerulonephritis. It's very common, and immunosuppression have side effects. So it is important to assess the risk of progressive loss of kidney function. In mild cases, usually we must wait to assess if that spontaneous remission might happen or not. While in more higher risk categories, we can implement then immunosuppressive drugs, taking the risk of adverse effects. We will show it now. These are the clinical criteria for assessing the risk or for classifying patient with membranous glomerulonephritis. Usually we classify patient to low risk patient, moderate risk patient, high risk patient, and very high risk. يبقى we classify patient low, moderate, high, and very high. Who are the low risk patient for progressive, at the lower risk for progressive loss of kidney function? Patient with normal GFR, proteinuria less than 3.5 gram per day, and serum albumin more than 3. يبقى normal GFR, proteinuria less than 3.5, and serum albumin more than 3. Moderate risk patient with normal GFR, proteinuria more than 4 gram, with no decrease of 50%, which is the criteria for remission. No 50% decrease in proteinuria after 6-month therapy of conservative therapy of antiproteinuric drugs with ACE and ARBs. So in patient without remission after 6 months of antiproteinuric drugs, what is the definition of remission? 50% decrease in proteinuria. Also in patient with phospholipase A2 receptor less than 50, now it is present in the criteria الassay with levels. If there is mild low molecular weight proteinuria, and if the selectivity index is less than 0.15 and urinary immunoglobulin G is less than 250. These are the criteria for moderate risk patients. For high risk patients, here GFR became to decrease less than 60, proteinuria more than 8 gram for more than 6 months, phospholipase A2 receptor assay more than 150, high low molecular weight proteinuria, selectivity index more than 0.2, and urinary immunoglobulin G more than 250. Very important. A very high risk patient with life-threatening nephrotic syndrome, patient with rapid deterioration in kidney function, patient with high low molecular weight proteinuria in 2 urine samples collected with interval of 6 to 12 months in 2 occasions. Here high low molecular weight proteinuria, here high low molecular weight proteinuria in 2 urine samples 6 to 12 months apart. Very important to classify your patient. This will guide us in choosing the appropriate regimen. Most of the studies have used serum creatinine values to guide in management, with serum creatinine value of more than 1.5 often used to define kidney insufficiency, and also a GFR of less than 60 milli per minute defines kidney insufficiency in young adult. So both are used, serum creatinine of more than 1.5 and estimated GFR of 60 or less than 60. But when we are using estimated GFR, age should be taken into account. It's very important. Regarding the cut-off values, when we are using assay, phospholipase A2 receptor antibodies are not validated yet. Cut-off values. We should rely upon the trend of the assay. It is either increasing or decreasing. We shouldn't depend on absolute values. Assay antibodies should be measured, as we said, every 3 to 6 months, even with a shorter interval if the assay is very high result from the start. Changes or the trend during follow-up is very important, because disappearance, as we said before, disappearance usually precedes clinical remission and should refrain us from additional therapy. Again, in most of patients, it is reasonable to wait 6 months for spontaneous remission while using maximal antiproteinuric therapy. It is reasonable to wait for 6 months in most of the patients. But in patients with high levels of proteinuria, high levels of phospholipase A2 receptor antibody, or low molecular weight proteinuria, evaluation should be earlier. We shouldn't wait for the whole 6 months. These are high risk criteria for progressive kidney damage. We shouldn't wait for the whole 6 months. We can re-evaluate before 6 months. Even after 3 to 4 months, if we found no response, we can reconsider our management and start immunosuppressive treatment. Patient with deteriorating kidney function or severe unresponsive nephrotic syndrome might be considered for immediate immunosuppression from the start if they have severe form or already persistent kidney deterioration. A survey of literature which document these recommendations that there is 45% chance of spontaneous remission in patients with proteinuria more than 4 grams after 6 months of conservative therapy, which will decrease to a 34% chance of spontaneous remission in patients with proteinuria more than 8 grams. So with higher proteinuria, the incidence of spontaneous remission decrease from 45 to 34. What about treatment? What about treatment in KDIGO 2020? All patients should receive optimal supportive care. As for general treatment for all nephrotic patients, antiproteinuric therapy, treatment with dyslipidemia, and for hypoalbuminemia and anticoagulation. All patients should receive supportive therapy. But immunosuppressive therapy should only be restricted to patients with risk for progressive kidney injury, as we described in the table before. For patient at risk, patient at very low risk, we should wait and see, leaving the option for spontaneous remission. Very low risk in patient with proteinuria less than 3.5 gram and serum albumin more than 3 with normal GFR. This is a suggested algorithm for treatment patient with membranous nephropathy according to the risk stratification. In patient with membranous, we should, as we said, we should do risk evaluation. In patient with low risk, we should wait and see, giving all supportive measures. In patient with moderate risk, we can wait and see, can use rituximab or calcineurin inhibitors. In patients with high risk, options are rituximab, cyclophosphamide, calcineurin inhibitors plus rituximab. In very high risk patients, cyclophosphamide is the option. Cyclophosphamide is the treatment of choice in very high risk patients with life-threatening complications of nephrotic and in very aggressive forms. CNI monotherapy is less efficient, especially with a short duration of less than 12 months. CNI should be prescribed for more than 12 months due to a high relapse rate if using a shorter duration. The use of CNI will shorten the period of proteinuria, and in high-risk patient, as we see here, in high-risk patient, we can add to CNI, we can add rituximab after 6 months. This will augment the response. Again, low risk, wait and see, moderate risk, rituximab CNI, high risk, rituximab, cyclophosphamide, CNI, and rituximab. In very high risk patient, cyclophosphamide. Again, immunosuppression is not required in low-risk patients with proteinuria less than 3.5 gram and GFR more than 60 ml per minute. Immunosuppression is not required in patients with membranous nephropathy, nephrotic syndrome, and normal GFR unless there is at least one additional risk factor for disease progression, as we said in table of risk stratification, or there is serious complication of nephrotic like AKI infections, thromboembolic events have occurred. يبقى immunosuppression are not required in patients with normal GFR only unless there is one additional risk factor for progression or serious complication have occurred. This is the recommendation. At least one risk factor is needed. You can use rituximab, cyclophosphamide and steroid for 6 months, or tacrolimus-based therapy for at least 6 months. The choice of therapy is dependent on, very important, the choice of therapy. Which you will choose CNI, rituximab, cyclophosphamide, on patient characteristic, drug availability, efficacy of the drug, patient or physician with social preference, policies, and the specific side effect profile of each drug. Very important. Side effect profile and efficacy of the drug. A very important note that we should know about the available treatment options for membranous. Randomized controlled trials and cohort studies have shown that rituximab and CNI are efficient, increase the rate of complete and partial remission. They are efficient drugs. The beneficial side effects, this is also a very important note. The beneficial side effect of these drugs favor their use over cyclophosphamide. Cyclophosphamide have a more common and dangerous side effects more than CNI and rituximab. So they are better options in patients with membranous with maintained kidney function. This is the rule. This is the determining factor. If a patient which have a maintained kidney function, so the better options are rituximab and CNI. But if the patient have a higher risk for kidney failure, if there is kidney damage or kidney deterioration, then cyclophosphamide will be the better option. In maintained kidney function, rituximab and CNI are better option due to limited side effect profile, while in patient with kidney, this is the rule, and in patient with kidney damage, cyclophosphamide is the best option. Regarding treatment, a very important also note that with treatment with CNI, there is a high relapse rate. This is the side effect of treatment with CNI in membranous, that CNI have the highest rate of relapse between rituximab, CNI, and cyclophosphamide. This is the drawback of CNI toxicity. It has a higher relapse rate. Alkylating drugs, chlorambucil and cyclophosphamide, are toxic drugs with severe short and long-term side effects. Cyclophosphamide is better than chlorambucil. Cyclophosphamide is better than chlorambucil. What is the evidence for these recommendations? There is moderate quality evidence that alkylating agents, which are cyclophosphamide and chlorambucil, and cyclophosphamide is better than chlorambucil, are effective in patient with documented kidney function deterioration. So in patient with documented kidney function deterioration, alkylating agents are the best option. There is no evidence that rituximab or CNI reduce the risk of kidney failure. So in patient with kidney deterioration, again, alkylating agents are the options. There is moderate evidence that CNI and rituximab increase their complete and partial remission rate. As we said, they are effective drugs, but in patients with normal kidney functions. There is also a moderate quality of evidence that alkylating agents, as we said before, have more frequent and more severe side effects than rituximab and CNI. CNI and rituximab have fewer side effects. Again, CNI is associated with a high relapse rate. There is also moderate quality evidence that remissions are more persistent with rituximab in comparison to CNI. So lesser relapse with rituximab, a higher relapse with CNI. Rituximab and CNI are beneficial and efficient drugs in patients with normal kidney functions. In patients with deteriorating kidney functions, cyclophosphamide is the best option. This is the summary of recommendations. Again, rituximab and CNI have fewer and less side effects than cyclophosphamide. Therefore, most physicians and patients will prefer initial treatment with rituximab or CNI, as we said. Will prefer initial treatment with rituximab or CNI over cyclophosphamide due to better side effect profile. But in most well-informed patients with a very high risk, only in patients with very high risk of kidney failure, the choice would be to be treated with cyclophosphamide, because there is no evidence that rituximab and CNI have any efficacy in patients with kidney deterioration. So in very high risk category, cyclophosphamide is the option, as we said. Now let's talk about the different treatment regimens. In cyclophosphamide we have two regimens, cyclic regimen and the continuous regimen. Cyclic regimen, to give cyclophosphamide in 3 months, over a period of 6 months, we give cyclophosphamide in months 2 and 4 and 6. And the continuous regimen, to give cyclophosphamide in the whole 6 months period. So we can give cyclophosphamide only in 3 months, and we can give it in the whole 6 months. With cyclophosphamide, we use steroids. Methylprednisolone 1 gram for 3 consecutive days at months 1, 3, and 5, followed by prednisolone 0.5 mg per kg per day, Botticelli regimen. This is the Botticelli. Or we can give methylprednisolone, as we said. Methylprednisolone 1 gram for 3 consecutive days at months 1, 3, and 5, followed by prednisolone in the whole period, 0.5 mg per kg every other day. Here we give it daily in months 1, 3, and 5. Here we give it every other days in the whole 6 months. This is in the continuous group, months 1 to 6, and tapering after. This is another different regimen. Rituximab, different regimen. Rituximab, we can give it 1 gram dose of 1 gram IV twice within 2 weeks. Yeah, we can give 1 gram, and then after 2 weeks we give another 1 gram. Or we can give it in a dose of 375 mg per square meter weekly for 1 to 4 times. We can give it in 2 doses of 1 gram, 2 doses, or we can give it 375 mg per square meter 1 to 4 times. 1 gram 2 times, or 375 1 to 4 times, weekly intervals. Tacrolimus, Usually you give it in a dose of 0.05 to 0.01 to 0.1, from 0.05 to 0.1 milligram per kg per day in 2 divided doses, with a target trough level of 3 to 8, with a duration minimum 12 months. We cannot give CNI less than that. A minimum of 12 months. Usually we will continue more to avoid the higher relapse rate. Cyclosporin, usually in a dose of 3.5 milligram per kg per day in 2 divided doses, with a target trough level of 125 to 225 microgram per milli. These are the different regimens for treatment of membranous. Cyclosporin and tacrolimus are often used in a combination with prednisolone 10 mg per day. Very important. Usually given in combination with prednisolone 10 mg per day. After 4 months of starting CNI, if no response at all, withdraw. But if there is response, continue to at least 12 months. And then we can taper doses to lower levels. This is a comparison of 6 months versus 24 months. Look at the remission rate here. In 6 months, if we use CNI for 6 months, the remission is only 50%. Remission in 50%. While in 24 months, it is present in 100% of cases. In 100% of cases. At early stages, after 6 months, they were comparable. After 6 months, they were comparable. But after 24 months, there is a higher relapse rate in patients who received CNI for only 6 months, while in patients who continue more for treated for 24 months, the remission remain in 100% of cases. So again, we should use CNI. If no response after 3 to 4 months, we should withdraw from the start. There is no response. But if there is a response, we should continue for at least 12 months, and it is better to continue it for 24 months. What about the IV cyclophosphamide? Very important clinical point is that cyclophosphamide side effects are mainly dependent on the cumulative dose of cyclophosphamide. So most of us will prefer to use the IV doses because the cumulative dose is less than oral cyclophosphamide. But the problem is the evidence. There is no randomized control trials evaluating the efficacy of IV cyclophosphamide on kidney endpoint. Older randomized control trials using IV cyclophosphamide with deteriorating estimated GFR were negative. So older studies were negative. But intravenous cyclophosphamide might be considered in patients with normal GFR because, as we said, older data on deteriorating GFR were negative. So we can use IV cyclophosphamide in patients with normal GFR. In patients with the lowest possible cumulative dose is needed. Who are these patients? Patients with previous use of cyclophosphamide and patients with a childhood wish. Patients who want to have children. I should preserve the fertility as much as I can. So I need to give the lowest possible dose of cyclophosphamide, and in these patients should be of normal GFR, I can use IV cyclophosphamide. But in patients with deteriorated GFR, the option is oral cyclophosphamide. The MMF is not discussed because have very disappointing results for MMF from the previous KDIGO guidelines in all randomized control trials that MMF didn't increase the remission rate. So still MMF is having is considered a not good option or a poor option for treatment of membranous. Longitudinal monitoring of phospholipase E2 receptor level, as we said before, the diagram. Longitudinal monitoring at 3 and 6 months of therapy after start of therapy may be useful for evaluating the response. So it's very important for the level phospholipase E2 receptor for diagnosis and for follow-up and prognosis. Very important in our management. Can also guide us for adjustment of therapy, as we will see now. This is a suggested algorithm for using the phospholipase E2 receptor antibody assay in our management and changing our regimen. At 0 months, and here at 3 months, and here at 6 months. We started by rituximab, CNI or cyclophosphamide for 3 months, and then we measure the phospholipase E2 receptor at 3 months. If the assay become absent, negative, this is very good. If we are using rituximab, no additional therapy. If we are using cyclophosphamide, we should withdraw. If we are using CNI, we should continue. As we said, we should continue CNI for at least 12 months. And then after 6 months, we should repeat the assay. If it becomes absent or low, we should continue as we said. If rituximab, no additional therapy. If cyclophosphamide, we withdraw it. If CNI, we should continue to 12 months. But if after 3 months, we found that no change in the assay. If you are using rituximab from the start, we can give extra doses. We should give extra doses. We give rituximab either in 1 gram twice or 375 from 1 to 4 doses with weekly intervals. So after 3 months, if there is no change in the assay, we can give extra doses, or we can, if we are using cyclophosphamide, we can continue cyclophosphamide. CNI, we should continue if there is no change, and then repeat after 6 months. If there is moderately increase or stable or slowly increasing, additional therapy with standard agent we can add from the others, as we will see. We can use a combined therapy. If we are using CNI, I can add rituximab, or if rituximab, I can add CNI, or I can add cyclophosphamide. I can use combined therapy if there is after 6 months there is still an increase. The third option is that after 3 months I found that the assay is increased. If we are using rituximab from the start, I can give extra doses or add cyclophosphamide. But if I am using cyclophosphamide from the start, I can add rituximab. Here I will combine. If I am using CNI from the start, I can add cyclophosphamide or rituximab. So the idea is that if I have after 3 months, if I found there is increased assay, I should combine. If there is increase. And then after 6 months, if there is a still high titer, I should evaluate for if this patient is a resistant patient. In this case, is a resistant membranous patient. Very important algorithm of how to use the antiphospholipase E2 receptor assay in management of membranous. A large decrease in the assay, may indicate a good clinical response, but there is no defined cut-off values. But many experts consider reduction of 50 to 90%, 50 to 90% in the assay is considered a large decrease in the phospholipase A2 receptor levels. Very important note in our clinical experience is the cumulative dose of cyclophosphamide. The cumulative dose of cyclophosphamide shouldn't exceed at any time, shouldn't exceed 25 gram. Never to forget that. Shouldn't exceed 25 gram. This is usually equivalent to 6-month therapy of a dose of 1.5 milligram per kg per day. For 6 months, this will give us cumulative dose of 25 gram. And most of the side effects of cyclophosphamide are dependent on that cumulative dose. A lower cumulative dose of maximum of 10 gram must be used in patients who wish to conceive. Very important to discuss with your patient, especially if a young age who want to conceive. We should use then that the maximum cumulative dose of cyclophosphamide is 10 gram. CNI again is usually associated with a higher relapse rate, so we need to use them for a longer duration. In patient using rituximab, B cell depletion is insufficient to judge the efficacy of rituximab therapy. What about treatment of relapse? In patient have initial remission and then have a relapse. If the initial treatment is rituximab, in relapse we should repeat rituximab. If we are using initially CNI, we can use CNI and adding rituximab to CNI. If we are using cyclophosphamide, I can repeat cyclophosphamide, taking into consideration the cumulative dose, or I can add and use rituximab and CNI. But what about the definition of relapse? In patient with remission who responded characterized by decrease in the proteinuria more than 50% and normalization of the serum albumin. If the serum albumin became normal, this is a remission with decrease of proteinuria. And then a relapse can be defined if there is proteinuria, increase in the proteinuric level, which have been normal. If there is more proteinuria and decrease in the serum albumin after normalization, this is a relapse. But if the patient had decrease in proteinuria, but the serum albumin from the start did not decrease, this is resistance. So again, to differentiate between relapse and resistance, in resistant disease, there is no normalization of the serum albumin from the start. The proteinuria might decrease, but the serum albumin didn't normalize from the start. But in a relapse, there is a remission before, in the remission of decrease in the proteinuria and the normalization of the serum albumin. If there is after that, there is deterioration in proteinuria and decrease in the serum albumin after being normalized before, this is a relapse. Immunological monitoring is very important. If a patient have a clinical remission, but assay, phospholipase A2 receptor assay, still positive, this might be an evidence for resistance, an early sign for resistant disease. Again, phospholipase A2 receptor assay should precede the clinical course, should precede the clinical course, either remission or relapse, and this will guide us in therapy. As we said, cyclophosphamide can be repeated. However, we should take into consideration the cumulative dose. if a patient wanted to conceive and we want to preserve fertility, we shouldn't exceed 10 gram cumulative dose, and cumulative dose shouldn't exceed at any way 25 gram of cyclophosphamide. What about the resistance? Resistant cases of membranous, as we said, who have proteinuria didn't decrease or decreased but not normalized, and serum albumin did not normalize from the start. This we can define as resistant cases. Resistant cases. How can we deal with them? Before we start, we should consider our golden rule that in patients with deteriorating kidney function or decreasing GFR, the best option is cyclophosphamide. If there is normal GFR, we can use CNI or rituximab. But if there is deterioration, we should use cyclophosphamide. This is an algorithm for how to deal with resistant cases. If they have initial treatment with rituximab, and then they have resistant disease, I should look for the GFR. If the GFR is stable, I can add to rituximab CNI. But if there is decreasing GFR, I should use cyclophosphamide. And if I am using combined therapy, CNI and rituximab, and no response after 3 months, and then I can use cyclophosphamide. What about using CNI from the start? Again, if the GFR is stable, I should use rituximab. If the GFR is decreasing, I should use cyclophosphamide. And then if I am using rituximab as like above, if after 3 months of using rituximab and CNI no response, then I should use cyclophosphamide. If I am using cyclophosphamide from the start and there is a resistance, if the GFR is stable, I can use rituximab. If it is decreasing, I should continue using cyclophosphamide. And if there is no response after 3 months, I can use cyclophosphamide. If no response or there is resistance after using rituximab and cyclophosphamide, and then I should refer to expert centers to use some of the trial options for these patients. In resistant cases, in our evaluation of resistant patient with resistant disease, compliance is very important. Compliance is very important. The option or the choice of the second treatment, as we said, is dependent on the deterioration of the GFR. If the GFR is maintained, we can use rituximab or CNI as a second option. If there is deterioration of GFR, cyclophosphamide is the option. And then we should check the response by proteinuria and phospholipase E2 receptor after 3 months. Patient who did not respond to cyclophosphamide and rituximab should be consulted to refer to an expert centers. They might choose one of the experimental therapies, bortezomib, daratumumab, and antibody to CD38 and belimumab, or using a higher doses of conventional immunosuppressive therapy. What about in transplant recipient? If this patient with membranous nephropathy became end stage and want to have a transplantation in patient with severe cases of membranous reaching end stage. Evaluation and pre-transplant evaluation is very important. The effort is mainly to search if this membranous patient is found to have phospholipase E2 receptor associated or not. We should measure phospholipase in this recipient. We should measure phospholipase E2 receptor assay. If it is positive, so there is a higher risk of recurrence. Phospholipase E2 receptor antibodies are associated with a higher recurrence rate after transplantation. So the recurrence rate is high, approaching 50%. While if it is negative, if these antibodies were negative, so there is a low risk of recurrence, approaching only 10% of cases. If these assay are negative, we should retrieve and we should search for the native kidney biopsy and stain for the phospholipase A2 receptor antigen. If it is positive, and then these antibodies now are negative, so there is a low risk of recurrence. But if the patient from the native kidney biopsy from the start was negative for phospholipase A2 receptor, so there is a medium risk of recurrence. Again, this point. We can retrieve the native kidney biopsy and stain for phospholipase A2 receptor antigen. If he was positive in the biopsy and then now become negative in the serum, this is a very good sign, indicating a remission, a very good remission, or very good response, that the recurrence will be at lowest level. But if the patient was negative from the start in the biopsy, and now he is negative in serum, also he was negative in both the biopsy and serum, the recurrence is medium risk, around 30%. If he is positive now, highest risk. If he was positive in the biopsy and then become negative in serum, lowest risk. If he was negative in biopsy and negative in serum, so he is at a medium risk of recurrence after transplantation. We should discuss this recurrence rate with the patient. What about the monitoring peri and post transplantation? We should measure the proteinuria every month. If the proteinuria exceed 1 gram per day, we should do biopsy. In patient with phospholipase A2 receptor antibody associated membranous with positive, we should measure the assay every 1 to 3 months, depending on the pre-transplant antibody assay. If the assay is increasing, there is increasing incidence or risk of recurrence, we should consider kidney biopsy at earlier phase. If the assay is decreasing, there is a lower likelihood of recurrence, we should defer the kidney biopsy and only doing it if we need it. We shouldn't do kidney biopsy at this stage. What about treatment of recurrence? We should treat with ACE inhibitors or ARBs. We should optimize the immunosuppressive therapy. If the proteinuria is less than 1 gram, we should evaluate or re-evaluate at 1 to 3 months interval. If the proteinuria is more than 1 gram, we can treat with rituximab 1 gram, 2 doses, 2 weeks apart. This is how we treat recurrence, how we follow the patient's transplant recipient after transplantation. What about treating children patients with membranous? There is no evidence to guide our management of membranous in children. We should perform kidney biopsy. What are the treatment peculiarities in children versus adults? What is the difference? A wait and see strategy of 6 months to see if there is spontaneous remission is usually not adopted in children. Very important. A wait and see strategy not adopted in children. Usually, children with membranous are usually treated with prednisolone for at least 8 to 12 weeks. Rituximab and CNI are usually employed at the standard doses. We should exclude the secondary form, mostly lupus and hepatitis B. We can measure Assay titr if positive, can be used to confirm remission and detect a relapse. If negative, especially in children less than 6 years, we consider a role of immune response to cationic bovine serum albumin, as we said in the pathogenesis. Anticoagulation. Prophylactic anticoagulation or anticoagulant therapy in patients with membranous and nephrotic syndrome should be based on the estimated risk of thrombotic and risk of bleeding. Nephrotic syndrome is associated with an increased risk, as we know from the start, increased risk of venous thromboembolism and arterial thromboembolism, and the highest risk is present with membranous. We said it in part 1. The most common glomerulonephritis to be associated with thrombosis is the membranous. The risk of thrombosis is particularly increased in the first 6 to 12 months after the disease. This is a suggested algorithm for anticoagulation therapy in membranous. If the serum albumin is less than 2, so there is a higher risk of venous thromboembolism. We should assess the bleeding risk. If there is a high risk of bleeding risk, then we should use an aspirin. If the bleeding risk is low, we can use a warfarin or low molecular weight heparin plus aspirin. But if the serum albumin is more than 2 but less than 3, we estimate the arterial thromboembolic risk. If there is low risk of arterial thromboembolism, we shouldn't use aspirin. But if there is a high risk of arterial thromboembolism, we can give aspirin. But if the serum albumin is less than 3, if the serum albumin is more than 3, we shouldn't give aspirin. Again, if the serum albumin is less than 2, we should assess the bleeding risk. If there is a high risk of bleeding, we can use aspirin. If a low risk of bleeding, we can use warfarin or low molecular weight heparin plus aspirin. If the serum albumin is more than 3, we shouldn't give aspirin. If less than 3 but more than 2, we should estimate the risk of arterial thromboembolism. If there is a low risk for arterial thrombosis, so we cannot using aspirin, but if there is a higher risk of thrombosis, we can give aspirin. Our home message: don't forget, please, to evaluate for the associated or the secondary causes of membranous. Don't forget to exclude the malignancy, systemic lupus, and hepatitis B, and take drug history. Don't forget that very important to stratify your patient, to know in which risk category are patients. Are they in the low risk, moderate risk, or high risk, or very high risk? Treatment is dependent on the risk evaluation. In low risk, we can wait and see. In moderate risk, we can give rituximab CNI. In high risk, we can give rituximab CNI cyclophosphamide. And in very high risk, we should use cyclophosphamide. How to treat, or how to use Assay in our treatment? After 3 months, if the Assay is absent, there is very good option. We can stop rituximab. We can withdraw cyclophosphamide and continue CNI. But if there is no response, we should continue after 3 months. No change we should continue cyclophosphamide and CNI and can give extra doses, but after 6 months we should, if still there is increasing titr, we should use combined regimens. But after 3 months, if there is increased in the assay, we should give combined therapy. And if there is no response after 6 months, we should evaluate for resistance. Thank you. Inshallah we will continue in the next video. Ramadan Kareem for everyone. Thanks.